Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a clinical nurse educator specializing in NICU education. Today we are going to talk about hyperbilirubinemia. I got some messages in my DMs on Instagram asking some questions about this, so I thought we'd do a quick review of hyperbili and how we treat it in the NICU. So this is what we call jaundice, right? Or the yellowing of the skin, or when you hear people say, oh, I needed to take my baby outside because her skin was yellow. That's what hyperbilirubinemia is. To be honest, I love the word hyperbilirubinemia. It's right up there with medulla oblongata for me. I think we've talked about this before, but I will probably just start saying hyperbili at this point, just to shorten that up for all of us. But this idea is red blood cells break down. They create this byproduct called bilirubin, and it has to be kind of processed in the liver. When a baby is born prematurely, everything is premature, underdeveloped, not ready to do things that it's not set up to do. Right? In utero, the liver is not responsible for breaking down all of this bilirubin and processing it. So, because of the placenta, remember our old friend, the placenta helping out so much. So when a baby's born early, not only are we asking them to understand how to regulate their temperature and to breathe and to transition the circulation within their heart, and all of these things are going on. But additionally, we want you to now process bilirubin. It's crazy. So we should kind of expect that a baby in the NICU is going to experience hyperbili. Phototherapy is what we use to treat it most commonly. I don't have a great statistic for you, but I would say the majority of typical hyperbili cases, probably in the high 90s, are going to resolve with phototherapy. But we have to watch our levels closely because there can be long-term negative outcomes. This is a question that tripped me up for a long time, I'm going to be honest with you, and I've been asked a few times in my DMs. So I wanted to pause and talk about what is the difference between indirect and direct bili. You might see this on your lab report, you might get it in report, and you would say to yourself, what are they talking about? So indirect bilirubin is the unconjugated bilirubin. They are two words for the same thing. It is circulating in the bloodstream before it's processed by the liver. It is in the blood. It's kind of just hanging out there. It's what we treat with phototherapy because the phototherapy is shining down into the skin and getting into the blood vessels and doing the job of what kind of the liver does. And it basically is telling us, hey, I haven't had a chance to be broken down in the liver. Whereas direct bilirubin is conjugated bilirubin, that the liver is processed and it's gone through the liver, but it needs to get excreted and it's just not able to do that. So this is conjugated bilirubin. It's been processed. If it's not processed well, if the liver is not unable to do its job, the liver will often be damaged from prolonged TPN use. In the NICU, we don't really have benign treatments. TPN in and of itself can be harmful to a baby's liver over time. Maybe the baby's liver took a hit maybe during something like HIE or a sentinel event during their delivery, and we have some damage going on. So the liver is unable to fully process and excrete the bilirubin out, and we have to treat this with medication. Phenobarbital is a medication that's used to treat high direct bili levels, as well as ursodiol or Actigol. So when you think about if your baby is, let's say 18 hours old, 28 hours old, 38 hours old, and they say, oh, your indirect bili is 7.8 with a direct of 0.2. Well, that's great, right? Your indirect is rising, and it's all going to depend on, the age of the baby in weeks and hours, which we'll talk about. But that's what we're going to treat with that phototherapy. And that direct at 0.2 is pretty normal. When that direct gets really high, your baby's in this liver damage, where that's not what phototherapy is going to treat. We have to treat that with medication, finding a way to stop our TPN, getting our diet ramped up if we can. This happens sometimes in short gut kids when they can't eat a lot, and so they're on prolonged TPN. So just something to think about. So I went through and read probably a lot of articles. You know how I am. I just love to read articles. And so it kind of created this table just to kind of break down that the older the baby is in weeks, the more likely we are going to tolerate higher levels. However, we are going to look at the levels based on how many hours old they are, and what the rate of rise is. So these are two different, from a couple of different sources, which are linked here if you want to go and look at them. And you can also message me and I will always send you the articles. This is really talking about kind of an evidence-based table and then what a specific unit created based on the evidence for treatment for their patients. The evidence also does tell us that once a baby's bilirubin is less than 5, it is really difficult for phototherapy to be able to break that down. So in that case, maybe it's better if we stop the phototherapy so that maybe the parents can hold and work on things like bonding or swaddling if the baby is kind of moving around a lot. But above 5, there is some room for treatment, but thinking, what is the rate of rise and how many hours old is the baby? So when we're talking about a premature baby, those babies born less than 34 weeks, we talked about our immature liver function, right? The liver primarily processes and excretes bilirubin. So this immature liver that can't do it at the rate it needs to as the red blood cells from mom and delivery and all that are breaking down, it will create higher levels. Bilirubin is also excreted in stool, right? So urine and stool are the two primary places. Urine comes from the liver and all that processing, and the stool comes from our gut. If we are not feeding the babies, they can't do this processing within their gut. And furthermore, they are not pooping. So the delay to that first stool, the delay to transitional stool are all going to contribute to an infant's bilirubin levels. We also are going to have situations where we have the babies going on and off phototherapy. Number one thing I tell parents about a baby born less than 34 weeks is I personally, I'm coming up on 21 years, have never seen a baby born less than 34 weeks leave the NICU without phototherapy. I can now say I've seen them leave without antibiotics. I used to not be able to say that because we used to start them on everybody, as we've talked about. But now I can still say pretty much everyone born less than 34 weeks, in my experience, goes under phototherapy. It's kind of like this rite of passage, welcoming to the club. We expect it. We know that the liver is unable to do this job. So this is one of those expected outcomes. And as the levels are coming down, they may come back up. So just think about that as you're explaining it to parents. You might see the lights come off, and it is normal. We're going to recheck the level in 24 to 48 hours for them to need to go back under the light. For our late preterm infants, those babies born between 34 and 37 weeks, they may have feeding struggles. They're not effectively taking food by mouth, which can, slow down that biliary excretion. They may have low milk supply, which can lead to dehydration, and that can also increase the bilirubin level because we can't get it out enough. And then that delayed meconium passage, same idea. These babies are often sometimes where you're going to hear the phrase breast milk jaundice, and really a lot of that, there's this confliction between, is it because of something in the breast milk, which it can be, but also it's because they're not getting the same amount of fluids. So sometimes they need to be supplemented with formula or IV therapy if their bilirubin is really high. For the babies born greater than 37 weeks, they are still also at risk. This can, similar ideas. If they took a hit from during a sentinel event, something that's going to lead to something like HIE. But additionally, ABO and RH factors, there are a lot of factors that we're learning more and more about on the blood cells. And if the baby's factors are incompatible with the mom's, this is going to lead to excessive red blood cell breakdown, so releasing even more bilirubin. There are genetic conditions. There's a few out there. Just two mentioned here is the G6PD deficiency. So this is more common in certain populations, but it leads to a higher bilirubin from the red blood cell breakdown. And then Gilbert syndrome is a liver disorder. So yes, term babies are less likely to need phototherapy, but that doesn't mean that they don't receive it. And babies born greater than 37 weeks, especially with some of these RH factors or other factors on the red blood cells or ABO incompatibilities, are actually going to need more intensive treatments, which we're going to talk about a little. But let's first talk about phototherapy. I went on a deep dive about how phototherapy started. And at first I saw this said that, it was in the 1950s, the late 1950s, with research conducted at a hospital. And it was talking about, what this research was going on. They were trying to figure out how to reduce jaundice levels. And the nurses were putting the babies by the windows. And so the nurses observed that those babies placed by the windows were more likely to have their levels come down faster. And then in an article published, I printed this off here, in 1983, so when I was 2 years old, they started looking at the optimal wavelengths of light and what would be best to break down the bilirubin so that it could be excreted into the urine and into the stool. And that's when we started looking at the idea of the blue spectrum. So the most effective wavelengths was the blue spectrum, and green light was actually found to be completely ineffective and in fact was raising some bilirubin levels. So when I started, we had babies on these circle white spotlights that had a 1, a 2, and a 3. I remember we would turn the little notch, and you would try to get that to cover as much of the baby's body. And then maybe if it was really high, we had a few of these blue lights, and now everybody is on blue light phototherapy because we know it happens so much faster. So it involves exposing the baby's skin to this blue light that alters the bilirubin molecules, converts bilirubin to water-soluble isomers. So now they don't have to be they don't have to be processed in the liver. They're not getting that whole metabolism going on, and that water-soluble bilirubin can be excreted into the urine and the stool. And that is how phototherapy works. And that is why you need that Billy light to cover as much of the baby's skin as possible. And you can do that. You can also rotisserie chicken them, right? Put them on their back, on their side, on their stomach. So you're getting all the surfaces of the baby so that we get exposed to different red blood cells. Do not forget how much blood and surface area the head is. Also, to those term risk factors that I did not mention on that last slide that I meant to mention is with the cephallohematomas and the capits and where blood is getting pooled, that is also going to increase the risk for needing phototherapy for hyperbilirubinemia. But this blue light is very non-invasive. It's very effective. It's safe. There's a measurement to make sure you also are getting good radiance. You can measure how far the light is away from the baby. It doesn't generally warm them. You will sometimes notice on small babies when you take the light away and you're starting to do your care time that there might be a change in your temperature, but it's not a heater per se. But really this idea that the phototherapy is using that blue light to turn the bilirubin molecules into water-soluble isomers. That is the key. If I were explaining this to a parent, I would say this blue light shines onto your baby's skin and it kind of goes through the baby's skin to alter the bilirubin molecules so that they are able to attach to water-like substances to be able to be peed out. That's kind of how I would take down those words of bypassing liver metabolism, turning into water-soluble isomers so that they could understand what's going on. So treatments for severe hyperbilirubinemia, we use phototherapy, right? And then we can use IVIG. That's going to help a lot when we have the incompatibilities. So IVIG prevents the breakdown of the red blood cells. So if we have a lot of red blood cells breaking down and lysine and doing all of this, they're excreting this bilirubin because that's the byproduct. We just want to stop that, and that's what IVIG is doing. An exchange transfusion, I like to say that whenever you bring this up, you're going to see one. On average, most units see 0 to 1 of these per year, and it's a typical NICU situation. But this is when you can do a partial or a full exchange transfusion where you are pulling the baby's blood out and at the same rate replacing it with donor blood so that we can get this breakdown and stopping and get the bilirubin out of the baby. So this is kind of what that setup looks like. The blood is gradually removed. It's done in a very controlled fashion with lots of labs, lots of blood pressure being monitored, urine output, hydration status, etc. So this is for those dangerously high bilirubin levels are rapidly rising. I have seen exchange transfusions most commonly in the first 24 hours of life when the bilirubin level is running so fast, its rate of rise is so high that we can't bring it down. It is effective, but it does have risk factors, especially with clotting. That's a big one, right? We're pushing and pulling blood in and out. It can cause blood pressure fluctuations, electrolyte imbalances. There's been links between exchange transfusions and NEC, and that's probably to do with hypoxia and the changes in the blood flow and where we're prioritizing the flow of blood during an exchange transfusion. So again, it is great. It is a process. It involves a lot of people, a big team, and a very good communication as we're talking about what we're doing with going with the exchanging, how much blood's going in and how much is coming out. We also just want to make sure that we understand that this is a blood transfusion. We need to have consent and all of that going on. There are long-term effects if bilirubin levels get too high and stay high. So kernicterus, which used to kind of be called bilirubin encephalopathy, another great word, is this rare but serious condition where untreated jaundice in babies that occurs when the bilirubin just builds up too high and it crosses the blood-brain barrier. It damages areas of the brain. This was more common in areas where babies were maybe sent home or in more rural areas where there were not NICUs and they were having delayed follow-up appointments when late preterm infants were going home. We have a great follow-up system now. We do so much more with virtual check-ins and Zoom check-ins and all of that. Home care, going home and checking bilirubin levels either transcutaneously or sending it off to the lab. I have not seen kernicterus in a very long time, but it is something to think about and the developmental delays that it does cause. And we just need to be sure we're paying attention to it and make sure we're checking the levels as the baby is growing. So what can we tell our parents about this? We talked about the phototherapy and kind of how we can describe that to parents. We need to make sure we're encouraging bonding and getting the baby out to be held skin to skin, having the parents help with the feedings and the diaper changes. Is the bilirubin at a level that we could maybe use a billy blanket so that we could have the billy blanket on the baby's back while being held by moms or dad so we can increase their bonding. As the babies are going home, this is particularly true for our late preterm infants. We need to teach them to recognize the signs of jaundice and when to seek follow-up care. Sometimes babies go home, they're waiting for that billy level to come back, and then they go home. And I think sometimes, have we done enough? Have we done our due diligence to make sure that they understand kind of what the risk is for a rebound and how they can manage that at home, what their pediatrician is doing, when they're going to be seeing, all of those things. So to recap, hyperbilirubinemia really is a manageable condition. It's primarily treated with phototherapy. Babies primarily fully recover from it. Their livers develop and grow, and they do great. Understanding this idea between indirect bilirubin, that's the unconjugated and circulating in the bloodstream, versus the direct bilirubin, which is the conjugated, it's already been processed, helped my brain so much to understand indirect, unconjugated, not at the liver, needs phototherapy. Direct, conjugated, it's already been processed and it's still kind of stuck in there. The liver's not able to process it out, needs medication. Mind-boggling for me. Understanding these risk factors, making sure we're doing our frequent checks, making sure that during phototherapy we're giving the babies breaks from their little eye masks that they wear. We wear the eye mask to protect their eyes. That when we draw our labs, we're turning the phototherapy light off during the lab draw so it's not affecting the blood as it's coming out. That during an exchange transfusion or even IVIG, something kind of that we don't do often, that we're having great communication and checking in and doing a two-person on everything to make sure that we know what's going on, that our teamwork is solid, we can prevent these severe complications. And then, of course, engaging with our parents, maybe even making sure, hey, have you had a baby with high bilirubin before? This is something that could maybe happen again. Or on your next delivery, make sure you're watching for these things. This could happen again, especially if it's a blood incompatibility situation. So thank you for joining me today for this Teach Me Tuesday. I hope you learned something. And if you have any comments, questions, you can follow me on Instagram at the same handle, _Houston, _we, _have, _a, lots of underscores, I know. Houston, we have a. So today it'd be Houston, we have a Teach Me Tuesday. But let me know if you need anything, and I will see you next week for another round of Teach Me Tuesday.